Good morning, everyone. Welcome to Carilion Clinic's Pediatric Grand Rounds. Our speaker today is Dr. Susan Guelich, our very own pediatric nephrologist, section of one. But mighty. Small but mighty. She's a Blue Devil, trained at Duke, attended medical school at MUSC in Charleston, South Carolina, residency and fellowship at Vanderbilt. And she was the first pediatric nephrology fellow at Vanderbilt and the only one until 2 years ago. She broke the mold. Her first faculty position was at Wake Forest Brenner Children's Hospital. She moved to Roanoke in 2010 and worked at Valley Nephrology Associates and provided consulting services to Carilion for years. In October of 2025, she joined Carilion Children's full-time as our section chief, and she currently serves as Director of Wellbeing as well. Please join me in welcoming Dr. Susan Guelich.
All right, well, thank you. So today we're going to talk about just a potpourri of nephrology topics, some old things and some new things. Let's get started. You know how some people have pictures of their kids on their phone? And most of my pictures are PD catheters, because that's what I go to the kids' events at school, and the other moms are taking pictures, and I'm scrolling through my home therapy photo album. So this is a really healthy peritoneal dialysis catheter. And if it has epithelialized properly, it's just like a pierced earring hole. It's just skin. The catheter is a little bit mobile. It's anchored down here in the rectus sheath of the abdominal muscles, and these people you can literally just let it hang, put it in your pocket like this lady's done. This one's been traumatized. I had a patient who, these are adult. In my life before here, I took care of the adult home dialysis patients in the Roanoke Valley. And we have about 80 people who are on dialysis at home in Roanoke. That's a little more than 10% of our dialysis population, and so that's a pretty decent number nationwide. So we had a really great unit. And this is actually the unit where our kids will dialyze when we start having kids on peritoneal and home hemodialysis. So this has been traumatized. This guy, his kids put him in the basement on the pull-out couch. And he got his catheter stuck in the gears of the pull-out couch. So after that, each of my patients, as I started training, I said, no pulled-out couches for you. This is pus, and you can see the cuff of the catheter starting to extrude, and this is an acutely infected dialysis catheter. Once it gets infected like this, it's really hard to use. A lot of times those catheters just have to get pulled out. This is bloody peritoneal fluid, which can be a sign of peritonitis, or it can be a sign of menstruation. So this woman had bloody fluid once a month. This is our teaching dummy and our teaching smarty. And this is our team. So you can see that the patients are in really good hands. Each dialysis patient gets Princess Peach as their physician. This is the nurse manager over at the home dialysis unit playing Donkey Kong, and this is the social worker and the dietitian. So every patient gets a full set of caregivers, and these are the people that will be taking care of our kids, and they've done a great job taking care of my kids in the past. So shout out to them. Let's see. This is new. So this is home dialysis. It's not really, really new, but it's something that a lot of people don't know much about. So home hemodialysis is what we would choose for our own dialysis care. This is the next stage machine, which actually Guelich uses this for their continuous renal replacement in the ICU. Wake Forest uses this for all their ICU patients on dialysis. So it has a lot of different purposes, but home hemodialysis patients use this in their living room. They get a machine, they get this little setup, which is a water purifier, and then it actually makes being at the lake more fun. I mean, really. Look at this guy's like loving it. The margarita goes in, the toxins go out like we do, no problem. And I had a patient who every summer she and her brothers packed up her stuff and they'd do their beach vacation with their dialysis machine. The dialysis companies will deliver all the supplies right to your hotel or cruise ship or whatever. Even if you're going to Europe, they'll send over all your fluids. And this is a popular modality for the people who have retired at Smith Mountain Lake. So there's a lot of patients out there that do this. We had a patient who, he and his wife packed up their gear in an RV and traveled around the country for 2 or 3 months. I think 70 days he was on the road doing, he would set, the dialysis company paid him to go set up at different in-centers to kind of show off what he was doing. And they just cruised around. The only problem that he had was he hit the brakes too fast and his wife fell and broke her wrist, but he was totally fine on dialysis. It's not as fun as it looks, but it is a really good treatment option for dialysis. So a lot of people just don't know about this, and so I like to put it out there so you can see what some of the treatment options. This is just a picture of how you can pack it up and go. And one thing I love about this is it's kind of the intersection of everything you want to be as a doctor. It's empowering patients to do their own care. It's allowing patients to go to school and work and not have to go on disability. It's not having to go sit in a unit. You stay at home on your own couch with your own air conditioning and TV. And it has better outcomes, better survival rates, and less cost. So I like this just because it puts all the things together that you want as a physician and you want for your patient. So. Okay, so that's not what we're talking about today. That was just fun pictures from my phone. So we're going to talk a little bit about hypertension, kind of how we've changed our classification. We're going to talk about some polycystic kidney disease, new developments in genetic testing, some new medications, and updates on transplant. And the last one is just a subliminal message that I won't read out loud. Okay, and we're going to start with a really cool case. I can't believe that. This kid came in to me just in February, so this is kind of a brand new referral that we've had that went really well. I just wanted to go through some of it, work through it as a case with you guys, go through some of the details and learn some stuff. So PK was a healthy 5-year-old who went to have a dental procedure in far southwest Virginia. It's one of your patients. I gave him your cell phone number.
Thank you.
Under anesthesia, his blood pressure was 97/98. And as he woke up, it was still high. I don't know if they gave him some pain meds and sent him home, but they didn't treat the blood pressure right away. Later at home, he developed a massive headache, and his mom took him back to the ER where his blood pressure was 200/150. They did a limited workup. They did chest x-ray, EKG, and labs, and they consulted with a local hospital, another children's hospital that won't be named. Here's Dr. Gay. I said, be on time.
I would consider this clearly on time. You don't know my definitions.
Well,
I didn't want you to like trick me and not know something that I should know. It sounded like your plan.
Great questions are starting now, so you're right on time. Okay. So anyway, this kid turns up in the ER with a high blood pressure, normal x-ray, normal EKG, normal basic labs, and they started enalapril 1.5 once daily.
How are you doing?
Why are you laughing?
I'm a little tired this morning.
Okay, why is he laughing?
Weak response. Weak, right?
Weak, it seems a little weak. But they did arrange follow-up with cardiology. They actually sent him out, which we'll talk about that a little bit, like what maybe our management can do. In retrospect, yeah, he's had headaches ongoing for a while. Mom gives Tylenol or ibuprofen, and it does seem to get better. When he was, I guess this was when he was 2 years old, he was seen in the ER with Bell's palsy, and blood pressure was on the high side, but it's an ER visit. He was seen later for wheezing, and again, blood pressure was high, but it's an ER visit. He's sick, so they send him out. Dad has hypertension. He's on a single therapy. Mom had gestational hypertension with other pregnancies, not with him. And mom is a nurse, and she's been checking blood pressures at home. And they're maybe a little better, but still very, very high. Wesley's making a face. Okay. So he did get in with cardiology clinic the following week, and this was Tri-City Cardiology in Johnson City. They did a great job. So I want to give a shout out to some of the other peds specialists trying to make it work in small areas. And they had a normal echo. They sent Rene and Aldo, which were normal. They sent plasmabetnephrines. What are we testing for there, Dr. Gay?
What's that? Dr. Kraft was like stunned I was here.
Normal thyroid, normal lipid. So what are we screening for calling with the Rene and Aldo?
Sorry, Dr. Gay has me
Renal
cleaner or something.
Okay, renal artery stenosis. How about plasmabetnephrines? What are we screening?
Kind of like oniony.
Yeah. So I like plasmabetnephrine, fractionated plasmabetnephrine, one blood test. Something like 94% sensitive, 94 and 100. I can't remember if it's sensitive, but it's a great test. I don't do the 24-hour urines and all those things. I just send them. First of all, FEO is so rare. Like, you're usually just sending it out of kindness, I guess. I don't know. So anyway, that's the easiest test for me. Rene and Aldo are pretty easy tests. So, and they increased his enalapril to the whopping dose of 2.5 daily, which is pretty bold, and they sent him to nephrology. You don't want to hear Okay. So here he is in your clinic, my clinic, and his blood pressure is 145/87, so it's better, but it's still well over treatment level. It's over 95th percentile, or 95th plus 12.
Key to the rescue.
99. Anyway, so we're going to talk a little bit about what type of hypertension is this, how do we classify it, and what else do we want to do to try to figure out what's going on with this kid. Does anybody want to give me any suggestions? Nothing? What about a physical exam? What are you going to look for on the exam with this kid? What if I told you that he was still having headaches and maybe some vision changes? What are you looking for then on your exam? What?
I mean, like it could, I know this is nephrology talk, but you know, other causes of intermittent headaches, papilledema,
Yes.
headache, you could have ICP.
Yes, and you always want to try to do a fundoscope. I tell the residents when you come through, you always want to try to do a fundoscopic exam. You want to practice it on every single kid so that you know what normal looks like and you recognize abnormal. Best case scenario, you might see something called AV nicking. Do you guys remember AV nicking? So as the artery crosses the vein drops out because of the high pressure in the little retinal artery. You may see something else, retinal hemorrhage, which looks like, you guys are so regretting sitting up front. Probably could have sat back by the bagels and been left alone. You're looking for a retinal hemorrhage or cotton wool exudate was what I used to learn, like little white tufts. What are you listening for in the belly? Huh? A bruit. Even Dr. Herman is not saying anything. All right, I'm going to quit asking questions. I'll start calling on my nurses back. Okay, so you're listening for a bruit on exam. You're trying to palpate the kidneys, see if they feel enlarged. Let's go to the next. Let's talk a little bit about, so in 2017, the AAP, with the help of some nephrologists, went through and simplified hypertension recommendations. Basically, in our percentile charts, if you got over 13 years old, your percentile went over the adult standard. So you could have a blood pressure of 130/80 and still be considered a normal range. So they went through and cleaned that up. They took out some of the kids with obesity that had been included in the normative data. And they kind of standardized a little bit more with adult practice so that these kids could transition a little easier with their blood pressure management. And they also got rid of the word pre-hypertension and changed it to elevated blood pressure. So it's no longer like almost a diagnosis, but now a real diagnosis of elevated blood pressure. So these are how you evaluate kids in your clinic, but this doesn't necessarily apply to the kid that comes into the emergency room, right? So there's another kind of set, like a mindset for us when we're looking at sick kids, and that's hypertensive crisis. So that's defined as an acute episode of severely elevated blood pressure, and they don't give a limit for what the number is. In adults, it's 180 over 110. In kids, it's pretty much over stage 2, but you have to use your kind of discretion to say, does this seem like a high blood pressure, or are the symptoms consistent with that? So does this kid, when he first presented to the ER, he went in with a massive headache and a severely elevated blood pressure. So would you have called him urgency or emergency? I would have probably called him emergency because there's signs that something serious is happening, something possibly life-threatening, and end organ damage, which would be the brain, the most important organ, followed closely by the kidneys. And so what kind of scan, what might we have been looking for with this massive headache? If there, let's say there were some vision changes, what might we have been looking for in this kid? Gary? That's good. So we want to do an MRI to look for signs of posterior reversible encephalopathy syndrome. So occipital, I think it's an increased flare in the occipital lobes that can cause change in vision, headache, things that are related to malignant hypertension. But they didn't do that. They just put him on a little bit of medicine and sent him home, and he was fine, and that worked out well. So, okay, so they sent him to nephrology clinic for one reason only, and that's a renal ultrasound. I knew in clinic that you can get most places can do a decent renal ultrasound. So you can send him home and let him get an ultrasound at a local hospital or wherever they do ultrasounds. Like, most people are pretty good at that. But the one thing that you can't get is a duplex. So the nurse working in the clinic called over to, we do our duplexes in the cardiovascular lab. So the nurse called over, and this amazing guy who's now my hero named Kevin was like, sure, send him right over. And, which never happens. He said, has he eaten? And I said, maybe a little bit. And he goes, no. And I was like, no. And so you have to be NPO for the study, but Kevin was willing to work with us and get it done, which was amazing. So Kevin calls me and he says, there's no renal artery stenosis. The vessels are intact. The kidneys are really weird. Like, there's something wrong in the kidneys. I don't know what it is, but there's nothing wrong with the vessels. They were bright, they were shiny, there was echogenic stuff, they were super large. So we were immediately thinking of one diagnosis, and we sent him over to the Peds ER where he got this ultrasound. So I included a normal ultrasound because in my phone, in addition to catheter pictures, there's lots of pictures of kidney ultrasounds. Sometimes for fun, I flip through it with my kids, and they're like that, you know. But last week, Stella, my daughter, dissected a pig in science class, and she took a picture holding the little kidneys and sent it to me, and I was like, what was about right there? It smelled so bad. When she got in the car for school, I was like, Ben, is that you that stinks? And she's like, no, I thought it was my son, because, you know, naturally, he's 12. But it turned out to be her. Her fetal pig wasn't really preserved well enough, and it was like a little bit rough. Okay. I promised Dr. Gay I wouldn't be silly during this talk.
You promised you would be.
I promised I would be. Oh, okay, good. Then I'm good. So, a baby kidney in the newborn nursery is about 4 to 5 centimeters, and an adult kidney is about 10 to 12. And then in between there, if you're somewhere in there, you're probably pretty close. But this kid, his kidneys measured 13 centimeters in length, so bigger than an adult and more than double probably what his should have been. And then this kidney has corticomedullary differentiation, so you can see the difference between the cortex and the medullary pyramids. You can see there's no hydronephrosis in the renal pelvis, and it basically has a normal echo texture. You can't comment on the echogenicity without having the liver beside it, so you only can say that on the right kidney. So we don't know about that part, but we know the anatomic structure looks good. It looks like a sliced tomato. I've been saying that for 15 years, and I've actually had doctors like Ryan Fulton go, it looks like a sliced tomato. I actually taught him that like however many years ago. Isn't that made me so old that I taught Ryan Fulton? Okay, but anyway. This kidney, you're not seeing any corticomedullary differentiation. You're seeing some weird little, it just looks totally abnormal in the ultrasound. There's a lot of bright spots, echogenic spots, that you really can't well characterize. So we go on to the next scan. In this case, because we were in the ER, we're trying to move along, we did a CT scan. There's one thing that I see when I first look at the CT scan that makes me feel ill, and that is CT contrast. So I probably wouldn't have given this kid contrast, but his creatinine was 0.9, which seemed pretty normal, right? Like, so the adult radiology tech looks at it and goes, they're fine for contrast, but really for this kid, it probably could have like thought about that a couple other ways. But anyway, what you see here is there's no cortex. So there's like this little thin rim of renal cortex, but the center of the kidney is completely occupied by something else that's not renal tissue. So this is a polycystic kidney disease, and I don't know if you guys, we're going to look at the different types a little bit, but just offhand, does this look like your traditional ADPKD, autosomal dominant polycystic? That would typically be macrocysts. And here we're seeing something, but we're not seeing any macrocysts. We think we're seeing cysts. And so the parents are waiting in the waiting room to hear their result. I'm waiting at home, like with my phone like this. I'm calling the radiologist and I'm like, is it ARP? Like, is it this, is it that? The radiologist really didn't want me on the phone because I think he was reading all the sledding injuries that were happening. So, see the next picture. Okay. So this is the picture that we all had in our medical. Did you guys still have this in your medical textbook, or just like get erased from history? This is the baby with Potter sequence. So this is the classic anhydramnios look of a fetus with the flattened face, the beak-shaped nose, the club feet deformities, the bell-shaped chest. So compression deformities from not having any amniotic fluid. This can be from any type of anuric kidney disease in the baby, but ARPKD is a common one, autosomal recessive polycystic kidney disease. The other one, I mean, some babies are completely anephric. You may have a bilateral multicystic kidney. So there's some other things, but ARPKD is high on the list. Most of the time it's not compatible with life, but if you have a little bit of kidney function, enough to make amniotic fluid, then you can be successfully delivered. So ARPKD is extremely rare, 1 in 20,000 live births. Autosomal dominant polycystic kidney disease, in comparison, is really common. We have tons of it in the Roanoke Valley, lots of families. Here is 1 in 1,000, so we see it quite a bit. ARPKD presents during the prenatal period or neonatal period, and sometimes during childhood, but almost always in younger childhood. It's microcyst rather than macrocyst. It's a PKHD1 gene mutation, a fibrocystin protein, which nobody knows the exact purpose of fibrocystin. It can come with Potter syndrome. And the other main feature of ARPKD is liver disease. So these kids can have, they have congenital hepatic fibrosis of varying degree. And typically you either have really bad liver disease or really bad kidney disease. You don't always have both, but there are plenty of kids who have to have liver kidney transplant for treatment. Okay, in comparison, here's some more pictures from my phone. And this is the picture you see and you go, I do want to be a nephrologist, by golly. This is Dr. Gay. No. This is one of the transplant surgeons at UVA, and every time he checks out a set of kidneys, he takes a picture with them and then he sends them to me, which I love. So ADPKD is an adult onset disease. Usually you don't go on dialysis until you're around 60. Does anybody know the gene mutations for ADPKD? So it's PKD1 or PKD2, polycystic kidney disease type 1 or 2. And the two genes are similar but have kind of a different onset of disease. And does anybody know for your boards what other organ you have to scan? There's liver cysts, but they're incidental finding. They're not symptomatic. There's a buzzword.
Hi there.
Airy aneurysms, does that ring a bell? So cerebral artery aneurysms on the circle of Willis. A certain percentage of families with ADPKD. So when I have a kid with ADPKD, I always get an MRI just to screen. You have to, in general, you typically try to do it once after their teenage years or once when they're younger and then again. They do have a tendency to rupture, so a lot of these kids can have brain bleeds, headache, that kind of thing. There may be a family history of sudden death. It used to be that you only did screening if there was a family history of aneurysm, but now it's recommended in any patient with ADPKD. And we do have some kids in nephrology clinic with ADPKD. And then, I have to keep going with the pictures. All right. I think that looks like something I cooked for Thanksgiving last year, but so that's fine. But on the left, this guy, his belly was so big. I just thought he was a beer drinker, but it turned out it was all kidney in there. And they insisted on removing the kidneys before transplant because they take up a lot of space. They can impact how you eat. They take away space from your stomach and intestines. You have high blood pressure usually, and so the transplant surgeons like to take these out before they put in a transplant. So unfortunately in this guy, when they took out these kidneys, his blood pressure just tanked, and he was on like high doses of anything we could find to get his blood pressure up, Midodrine and other things. And then he was no longer transplant candidate because his blood pressure was too low. So yes, it's an interesting case. But so here comes the new. This is genetic testing for kidney diseases. It's a company called Natera, and this is their Renocyte panel. So Dr. Doherty keeps the kits for these in her office. It's just a cheek swab. And it screens for, does it say, there are 397 genes related to kidney disease, lots of different types. So if I have a kid with kidney and ear malformations, if I have a kid with cystic kidney disease, there's so many things. I can just do a quick cheek swab. The max out of pocket is around $200, and you have your result back really quickly. So this has really been a game changer for me in nephrology clinic. I've sent it quite a bit, actually. And just so that I'm not biased, there is another company, Gene Diagnosis, that has a panel as well. And it's great, but it's not quite as inclusive as the Renocyte panel. So PK, I'm doing on time, good. PK, we got his results back pretty quick. He does have autosomal recessive polycystic kidney disease. And Dr. Doherty has seen the family. There's 4 other kids, I think. So my question was, how many of these kids do I need to screen? How do I need to work on this? And so, interestingly enough, because Roanoke is a small world, my adult nephrology partner called me and he said, I take care of who has ADP, polycystic kidney disease, is ADPKD, and you just saw his grandson. So I'm talking to Emily and I'm like, oddly enough, his grandfather has ADPKD. So she's thinking ADPKD. We get this test back. And so there were some fun little mysteries in there. One thing I like about being a nephrologist is sometimes I feel like that chick from Murder, She Wrote, like Angela Lansbury. Yeah, that's the fun part of it, right? So actually, my dialysis team gave me a little Angela Lansbury bobblehead that I have, but okay, anyway. Genetics has already tested both parents, and they came back, each one is recessive for an ARPKD trait. So we haven't tested the grandfather, we don't know what he has, but now since each parent is a carrier, we're going to go through and test the other children to see if they're also, what their status is here. And all of that, this kid just came to me in February, so already in May, we know his genetic status, we know his parents' genetic status, and we're halfway through working through this. So it's really cool to me, because it used to be sending off genetic testing for polycystic kidney disease was a shot in the dark. It took forever. You really never knew. It's so anyway, this has changed things for us. So for ARPKD, there's no treatment really. It's basically you're looking at kidney failure, and it's just a matter of time when that's going to happen. 60% of kids are on dialysis by age 20, so the only treatment is transplant. Now, a DPKD is a little bit of a different story. So you treat their blood pressure, supportive care, you try to get them to drink plenty of fluids. And then if they're high risk, we put them on a new medication called, an old medication called tolvaptan. And this is a study, this is data that's extrapolated from the TEMPO trial, which is an efficacy and safety trial that was done on tolvaptan. And they found that depending on when you started the drug, you could stay off dialysis for an extra 6 or 7 years, which is huge because once you go on dialysis, your median lifespan is only 5 years. So to save yourself 5 or 6 years of dialysis is huge. So this drug is not approved. It's only 18 and up. So the pediatric nephrologists have just completed and published the data for tolvaptan use in high-risk children. They found it to be safe and efficacious. They found over a year's time, the children lost one. So if your GFR is 90 and it goes down to 89, that doesn't sound like a big deal, but if that happens every year, then you're down to dialysis level sooner or later. So they found that it was safe, it was efficacious, so sooner or later we will be probably using tolvaptan in our pediatric population. We have a couple of kids that want to be on it, and you can't prescribe it under 18. And I'd be remiss if I didn't put a nephron in my talk, so here it is. I don't like nephrons. I do like I love nephrons, but I don't like to put up this slide and have everybody revert back to medical school and go, oh, I don't do nephrons. But anyway, in the collecting duct, that's where your body is regulating water, where you're fine-tuning your urine. So if you don't drink much water and you don't eat steak, you don't really need this part. Like, we don't see RTA until you start eating steak for dinner. Infants eat applesauce. They don't need to regulate their pH as much as we do. Anyway, so here's where we're also acting on the aquaporin to adjust how much water we're getting rid of in our urine. So tolvaptan blocks the receptor, which prevents the body from prevents the aquaporin channels from coming into the lumen and reabsorbing water. So basically you can't hold on to water. It causes an aquaresis. So you put these patients on tolvaptan, they pee and pee and pee. And that fluid is fluid that's not going into their cysts and causing their kidneys to grow. So basically, you can tell somebody to drink 3 liters of water and they probably won't do it, but if you make them pee 3 liters of water, then they will drink for thirst. And that's how that's kind of the mechanism. They did this really cool classification study for the tolvaptan trials to see who's high risk and who needs to be on the med. Turned out to be such a useful tool that they developed that now all nephrologists use it for their patients to estimate their time to dialysis. There's you can go to the Mayo website, Google it, and you'll pull up a little chart where you enter your age and the size of your kidneys and a couple other things, and it'll tell you your estimated time to dialysis. So it's kind of a neat little tool that was meant to be a research tool that now has been applied clinically. Okay, so this is old and new, so we're going back to some history of medicine. This is Domenico Cotugno, an Italian medical scientist from Naples. He was interested, they had a lot of popes dying from edema, and so they were all trying to study like what's going on with our popes. And the edema could be from lots of different causes, liver failure, kidney failure, heart failure, all different things. But one way that they had to study was they would test the urine for various things. So Domenico boiled their urine, found clumps of white stuff that looked like egg white, and that was kind of one of the things that led to the discovery of proteinuria. So I always say he coined the term albuminuria, but it may have been some other guys, but right around this time is when they started learning about albuminuria. So if you boil the urine, you get these white clumps that look like egg white, albumin. And so I may have told you guys this before, but it's really important. So listen. You can give a man a fish, then he will eat for a day. But if you give him protein in his urine and boiling water, he can eat for lunch. So, my kids made me promise I wouldn't tell that, but I made it up, and I'm pretty proud because there's not a lot of good albumin jokes. And interestingly enough, we don't have, he created quite a library of literature about his proteinuria, and weirdly enough, his wife burned it all after he died, and it says for unknown causes, but I'm pretty sure he probably was using her crockery to boil people's urine, which is so gross. When I was a fellow at Vanderbilt, patients would bring urine in any kind of container, so we'd get water bottles, plastic cups, we even got like some crockery, and I would say, do you want this back? And you know, it's embarrassing, so the families go, no, but you know, they probably kind of did. Like, I kind of look back on it, and I'm like, I should have rinsed it out and given it to them. But now everybody gets plastic cups. But I did think, Dr. Herman, like, we could say, part of our budget, we could reuse it.
Good. That's possible.
Will this play here? Yes. Okay, so this is old and old. This is my lab, the urine lab at Valley Nephrology. And every single patient, we dip and look at the micro on every single patient, and if they have protein in their urine, we do those tests. Does anybody know, we're not boiling the urine, but does anybody know what we might add to make our albuminuria visible? Right, with ceviche. She's adding sulfosalicylic acid to urine to denature the protein. And so you can grade it based on how, like whether you see clumps or just trace. So I love, if anybody really finds this so cool, then you might be a nephrologist. Does anybody find this cool? Everybody? I would have been so smart and like I see this and I'm like, I could have figured that out. Like, I don't understand AI, but I could have boiled urine for sure.
But I wouldn't have come over and eaten one of your omelets.
Breakfast wrap.
Socially isolated.
Oh gosh, I've done way too early. I'm so sorry, but this is new. We're going from Domenico to Tawana. This lady is one of the first recipients of the pig transplant. So Tawana, when she was young, gave a kidney to her mother who had kidney failure. And when Tawana got pregnant, she got preeclampsia and lost her kidney. When you're a donor and you develop kidney failure, you automatically go to the very top of the list. So she was first up for a kidney transplant. That's how the organ procurement makes sure that people know that they're going to take care of them if something happens. Tawana got a kidney but lost it due to rejection. And she developed a lot of antibodies, so she wasn't a great candidate for other kidneys that came along. She had, I'm blanking on the word. She had antibodies to the other kidneys they tested her for. So one day the transplant coordinator, she's from Alabama, one day the transplant coordinator called her and said, we found a kidney for you, but it's a pig kidney. So Tawana went to NYU in 2024 and was one of the first recipients. What they do with it, they humanize the pigs by editing out some of their genes and editing in some of ours to make them HLA compatible and compatible in other ways. And so Tawana had her kidney. She woke up from surgery and said that she was the luckiest woman in the world. She had her kidney for 6 months, I think. It was removed a year ago, so April 2025. And now she's back on dialysis. She probably, there's no post recently about how she's doing, so I assume maybe not great, but they've had, after her, another fellow got a kidney that lasted a full year, and they're making progress with this every year. Obviously, there's a lot of funding for it because it'd be great to be able to have organs like that, kind of a ready supply. So I think Tawana is super cool. She said that it was worth it in every way and like just a positive attitude about it. But that just tells you what people will do to get off of dialysis, because dialysis really you can't live a full life on dialysis. So anyway, this is Tawana Looney, who I celebrate, and I do have some pictures of my family. This is the New York City Half Marathon in March. I'm trying to do a half marathon in every state, and I'm up to 11 states. And so this was mile 10. Kids came down. This is my 3 kids and my husband. And I'm sorry I went through that too fast. We're done really early. Do people have questions about nephrology? Yes.
Just with regards to like the renal duplex and kind of your referral pattern, are you wanting, because we're kind of at this crossroads, right? And I think I've still seen kind of one leaning where we have so much obesity and they're very likely this is all obesity related hypertension that we're sending to you. Is it still the recommendation that there's a large lab eval for these kids who have a BMI that is off the BMI chart? Developing
When you're
hypertension?
looking at kids under the age of 6,
Yeah.
they're highly likely to have a secondary cause of hypertension like this kid.
Yeah.
And especially the higher the blood pressure, the more likely to become. So under the age of 6, you can do your labs, urine, echo, renal ultrasound, duplex if you want, and then you can do a tiered approach, or you can just order everything. In teenagers, so like over the age of 13, especially if there's a family history of hypertension or obesity or other things, it's almost certainly 95% going to be essential hypertension or familial hypertension. So in those kids, I should do the first set of labs, which would be blood counts, metabolic panel, and urine, and probably lipids. And then you can think about lifestyle modifications, see how they respond to that. If you're thinking of starting a medication, then you definitely want your echo, and you definitely want to start some of the other workup.
Yeah.
So for screening, I think you could start with the basic lab work and lifestyle modification, and then see them back a couple of times and see how they're doing.
Yeah.
And it used to be that it was recommended to get an echo every year to see for LPH and other things, but now the recommendation has changed that if they're well controlled, their blood pressure's in goal range, then you don't have to necessarily get follow-up echoes. I do still get them every couple of years, 2-3 years, but maybe not every year if their blood pressure is good. The other thing is your goal with your blood pressure medicine is to get under 90th percentile. So you're trying to get a pretty normal blood pressure. You're trying to get as close, you're trying to get a normal blood pressure in these kids. So that's your goal with your medication. And other questions on that?
What is your application as far as almost inhibitor, but what would you prefer?
So if I almost always, in the little kids, I almost always start with lisinopril, which is a once daily ACE inhibitor. In the bigger kids, I'll start losartan, which is a once daily ARB. I don't start that in the little kids because the dosing just doesn't go down to the smaller weights. So I'll just always start with an ACE or ARB just because the data is so strong for preventing heart attack, stroke, any kind of vascular disease. Like if you look at data on ACE and ARB, just it does everything. It adds years of quality life. So I tell patients that we're not really treating the blood pressure. We're trying to prevent them from having a heart attack at age 40, like Dad. And so I start with an ACE or ARB, and then add-on therapy is pretty rare in kids, but you have some choices there. A calcium channel blocker is always really safe. So.
I want to say, I'm here. You guys know the cardiologists were trained to manage hypertension. Where are we with ambulatory blood pressure monitoring?
So thank you for asking that. Ambulatory blood pressure monitoring, if you read studies and data on blood pressure management, it's all ambulatory blood pressure monitoring. The blood pressure monitor itself costs about $2,500, and you can get You can bill it, so you can get about $50 to $80 reimbursement for each kid that you do it on. And when I first started, a long time ago here in October, which was like more than maybe 6 months ago now.
Wow.
Everything's changed, okay. When I started, I definitely wanted to start the ambulatory blood pressure monitoring. I was asking my colleagues, what machine do you buy, what do you use? And all the nephrologists were like, yeah, I think we bought a Suntech, a decade ago. It gets taken out, it doesn't get returned. It gets sent home, it doesn't get used. So it's very problematic. And actually there was a recent study in teenagers that found that the cuff was traumatizing. Over 50% of teenagers reported being traumatized by the use of this cuff. So I haven't pursued that. My mind could be changed if we wanted to do that. I talked to Jerry Lance, an adolescent, and she has a cuff that she loans out to kids and asks them to check blood pressure periodically and come back with the data. I did the same thing. I loaned a cuff, and I'm still waiting to get it back. That was a couple months ago. So there's just not a good answer to that.
How are the over-the-counter ones, like you can see at Walgreens and things?
There's a couple of brands that I recommend. There's an Omron. I recommend the Omron brand.
Spell that.
OMRON. And I've ordered some from Amazon just to trial. You can get cuffs that fit your wrist or your arm. So if the parents are, you can measure and order cuffs pretty cheap. Jerry, my nurse, is working on helping us figure out how to get these reimbursed. I think insurance pays for a cuff if you get the right pharmacist and the right prior authorization. So that's something we want to do too, is just prescribe cuffs for every kid that needs one.
Kind of a question of, should I alter practice? I have the school nurse do them and send them to me. I just ask them to do the same blood pressure every day, or same time every day. And I've gotten like decent data on that. I've gotten one kid who really had a high risk of having hypertension, who came back with hypertension across all, kind of all readings, and has responded to lifestyle management. And then most of the other time I'm getting kind of low blood pressures. And this is most of the time happening in adolescence. And so the cuff, it's a normal cuff for most of them. But is there any, or do you have a preference, or are there any data to say that like school-based monitoring has any benefit or whatnot?
No, I don't have data on that. There's such a wide practice in how they measure blood pressure. So we have one kid that we share that he says he runs to the nurse's office before he goes to class. She checks his blood pressure and he runs out. And I said, do you sit for a few minutes? He said, no. So his pressures are high. I do think it can be useful, but I don't want it to be disruptive to their school schedule, Yeah. And I have recently, if I have kind of borderline or highish blood pressures, I used to do a lot of lifestyle modification and waiting, like come back in 4 months, blah, blah. And I find that that's discouraging, I think. Like, I think they get home and they don't succeed with lifestyle modification and their blood pressure is still high and they don't come back. So a lot of times by the time they get to me, it's time to start a med. So I find that it's better to do the lifestyle modification counseling, but also start a medication so they can have some success. They can have a couple of good blood pressure checks and then they go, oh, okay. And so some encouragement. So I do tend now to start a medication right away, especially because there's just so much good data. And white coat hypertension is associated with bad outcomes. So even if, they're high in clinic but low in other places, they're still high a lot of times, and they still have worse outcomes than people that don't have white coat hypertension. So I've kind of started being a little bit more aggressive with starting them on a low dose of an ACE or an ARB. Does that make sense?
Yes, thank you.
So, I think it's the lowest number, the field of pediatric nephrology has the lowest number of graduates going into fellowship of any of the fellowships.
But here we have so many.
And why? and knowing that nephrologists all know each other and like each other.
Yeah, that's true.
They all have the same sense of humor. So, what advice can you give our learners who?
I'm not the weirdest nephrologist. Like, it gets is much weirder, honestly. At Vanderbilt, I waited till 10 o'clock for my mentor to come in when I was a fellow, and when he came in, he was wearing a Russian fur hat at 10 a.m., and I was like, he's the weirdest. But then it does get weird. But anyway, and what's funny is when I have people come for second opinions, I'm like, oh, maybe I'll call up Bunchman and see like what happened with this kid. Like they think that I don't know things, but like we all know each other. So yeah. What was your question?
Why and what advice to give learners to get them thinking about it?
When I teach everything.
Because nephrologists all love it.
It's so fun. I love it. I love being able to go different places. I can go to the ICU, the floor, the clinic, the dialysis unit, transplant, and these families. You might, like a post-strep GN, you get attached to them and then they're gone. You never see them again. But some of these families with CKD, you see them monthly for their whole lives. And like you're part of their life as much as anybody. So there's so many nice things about being a nephrologist, especially if you're easily bored like I am. Like when you get bored on one thing, you can switch gears and go somewhere else. So not to another town, just to another location in the town. And I think
selling crockery.
The teaching, I do a lot of teaching in the medical school, and the way they teach nephrology is so, nothing against our medical school, this is nationwide, the teaching is so unrelated to what we do in clinical practice. Like they put up these horrible pathology slides that don't even have, like I look at them and I go, that's not even anything, like they're pointing out stuff and you're thinking, I'm so dumb I don't see it, and I'm thinking, there's nothing there, like I don't know what they're pointing out, that's not relevant to anything, like. So I try to make it fun and not focus on some of that weird pathology that really is another. I just think the way they teach in the medical schools can be a little bit off-putting. And you don't have to be smart to be a nephrologist. Obviously, like you could be 1820 smart. You don't have to be 2020 smart. You know what I'm saying? Yes, Doug.
Susan, I've got a question.
Oh, no, you're talking about medical teachers. I'm sorry, I wouldn't say anything.
When the young man with ARPKD came into the ER, he was first evaluated in the ER, what was his creatinine there? I mean, his CMP was reported as normal, was it like 0.8, 0.9, which is clearly abnormal. And my comment is, you would make a wonderful warm-up for Leanne Morgan.
It's funny you say that. I am interested in comedy. Herman and I are thinking about taking it on the road, like a little show.
Improv. There's an improv group in town, and one of my first-year medical, just finished up the first-year medical students got involved with that.
There's
Do they like urine jokes?
they like everything, but there's somebody at the head of translation medicine does improv.
Oh, we heard somebody told us that. Yeah. Oh, yeah, we're ready. We're ready. We're going to take it on the road. Okay. Are there?
I got one final question because I think we're also at a crossroads. I'm gonna bring it back to clinical. So what is if you could forecast, I mean, like right now, you're building the department or the section, and so wanting to see these kiddos, but this is something that is going to move back on us, right, as general pediatricians. What is your forecast where, do you anticipate in the next 5 years, next 10 years that these 5 milligrams lisinopril, right, evaluation, these kids are really going to be the expectation cardiologists have been asking for a long time, but like when it really should be us who's really taking the reins on this and not going to you?
Well, I would say that blood pressure medicine is not something you guys prescribe every day. And when I think about blood pressure medicine, I know exactly what dose. Like I kind of look and go, you're about a 1.5. Like to me, it's something I do prescribe every day and I think about every day and I try to stay up to date on it. So when you're starting a kid on a med, monotherapy, you could handle. Endocrine prescribes lisinopril on their own a lot. When you're looking at the next level of therapy, for sure, I'd probably let me do that. I'm a little bit of a control freak. That's why I want to. There's so many nice things about nephrology. You can be a control freak. But lifestyle modification, 100%. And the other thing that really is a contributing factor now to teens with hypertension is adverse childhood events. So they're finding, and adverse childhood events are so common in our population, and all of those things are associated with hypertension. So anything you can do to address lifestyle is really important. I mean, yeah. A lot of it is purely stress, poor eating, not moving, all of those things. So that's why in the past I was slower to start a medication, because I wanted to do it the right way and have them live the right lifestyle. But to some degree that's not. It's discouraging to say go out and change your lifestyle. So. Yeah, awesome. Well, thank you guys.
Thank you.